डाल दे यार, इसके ऊपर ही डाल दे। हाँ सेक्सी लगती है ना अभी। हम्म।
नाइस।
निहार कहाँ गया?
ये सी लिखा
हाँ,
हुआ है क्या?
हम लोगों का
सी।
दोस्त बैठा है चेयर पर्सन कीर्ति पूनम या पहला जानी।
So if this comes towards left में, we can't access it. We want it to be like
वेरी,
this.
सर का और पहला जाने का और मेरा कीर्ति से जमता नहीं है ना, कि कीर्ति हैज एन ऑड बिहेवियर, फनी
आनी
फेलो।
नहीं चाहिए ये आ गया तो आप एक्सेस ही नहीं
हाउ
कर
आर यू
पाओगे
इटिंग?
कभी।
ओके।
ये आएगा तो एक्सेस होगा, या फिर ये आएगा
They
तो
don't like
एक्सेस
him.
होगा।
No. Some problem. If he has to have an introspection. If there is happening, what is? How are you with him? So yes or no? Neither nurse. Yes nor no.
Neither next yes or no, but I've had cases booked after him, and it's been a nightmare, sir.
Yeah.
Just 1-2 hours.
और सी कहाँ पे लगेगा, कोई फर्क पड़ता है? आगे लगे पीछे लगे?
Impossible. I never keep.
Yeah, I've done the hard way, sir.
Yeah, I never keep.
So जब सी पे this flush port faces up, right?
That it's going to be 4-5 hours. I didn't believe that.
Yeah, we just seen the valves.
Hmm.
So देखो लीफलेट्स तो यहाँ है,
हाँ
but see ओपनिंग और भी ऊपर है। See that?
हाँ.
It's so high.
Yeah.
That's good. ये इतना क्योंकि इसका आउटवर्ड फेसिंग है ना ऐसे।
Seal is a lot, no, sir. AR hopefully should be.
So sealing AR can only happen अगर आप इतना अंदर चले गए तो। देखो सीलिंग
Oh.
स्कर्ट यहाँ से यहाँ तक है,
हाँ
पर आप एनुलस यहाँ पे आ गया तो
हाँ.
साइड से सीवियर AR होगा।
बराबर. So margin of safety is high.
Is there?
But
Yes.
this in case, so AR is less of a fear, but
Hard block.
hard block
Yes,
is there.
बिल्कुल।
हाँ
ये ऐसे है ना, see this design? It's like this. So
हाँ
you know, but
सही बात है.
इसीलिए रेडियल स्ट्रेंथ भी है।
हाँ रेडियल स्ट्रेंथ भी है. $19 है ना. एंड पोर्साइन.
और उसका भी 19 है ना, पोर्टिको का भी। But probably the radial strength is because of the design of the interwoven, जो diamonds के कारण strength है।
So if you see that sir, all diamonds are not uniform. Lower diamonds are bigger.
लोअर इज 6.
Yes sir.
The
But
full
if you
diamond
see
is
आगे
10.
का 4.
10 sir, 10 and बाकी के सारे सब 8 हो गए तो dimension wise भी सब changes है
ये
देखिए.
मैं दिखाता हूँ सर, बड़ा इंटरेस्टिंग है। तो the full diamond is 10, half diamond is 6, and the upper part is 4. So when you crimp it on fluoroscopy, what you see is this is 0, and the first line is only half diamond. So from here to here is 6, and you're trying to land right there.
At 6.
No, 3 and 4.
3 and 4.
So what is 6? 6 is the distance from here to here.
करेक्ट.
That's it.
हाँ
अब ऐसे कोशिश करते हो यहाँ कहीं आ जाए.
हाँ.
When you see it outside,
It looks
it's like
small.
you're using so much precision.
Yeah.
It is,
Yeah. So this is this, the
True,
6 is only from here to here. That's it. तो आप 6 पे भी अगर लैंड करते हो ना, देखो ज़्यादा डीप नहीं होते हो आप.
नहीं ज़्यादा डीप नहीं होते.
So,
सही बात.
But outside समझो तो.
So error margin safety is
Is
good.
there? Yes.
Yeah.
But here what we'll start, start sharp between 0 and 1. So maybe like 3 mm you want to start 3 mm, because then we go very slow. कुछ नहीं है. चलो बलून प्रिपेयर कर लेते हैं. You mount
ready
it.
है.
Right. So what we'll do is this sheath will come out. We'll be going sheathless. तो फ्लोरो में नीचे हमें दिखाते हुए जाना होगा. Nihar, you want to tell your technician?
Say that again.
So when we'll be doing sheathless, this will come out, and you'll
Yeah.
be going inline sheath. So they have to they have to follow under fluoro.
हाँ या
वो बस उस समय
हाँ.
and fully demax so it's possible
पूरा
to be
demat.
able to see the wire. When we go up to the arch,
यार ये मेरा निकलने वाला है क्या? लगा उसको बुलाना है. ऑडियो वीडियो ये गिर गया मेरा. No, this thing, this mic. ये गिर रहा है. मेरे कान के ऊपर से गिर गया. कान कान के नीचे से कर रहे हैं, हाँ ऊपर ऊपर ऊपर.
TAVI patient, there are infective endocarditis with TAVI virus,
Yeah, they'll have, he might have.
and he recovered well.
हाँ,
Superb, yesterday's episode.
अब कैसा है वो?
मस्त है, बढ़िया लग रही है.
तो
एक साल अभी होने वाला है.
इम्यूनो सप्रेस्ड है ना वो बहुत नहीं.
हाँ, you know that person.
इतना टाइम हुआ हेपेरिन दिया है ना, तो देखो द प्रेशर ट्रेसिंग्स आर सो क्रिस्प,
Yes, yes, yeah.
नो डैम्पिंग.
No damping. Yeah. एक और आप इंचार्ज यानी यहाँ जब इंजेक्ट करेंगे ना तो इसका वो प्रेशर ऑफ ऑन करना है, जस्ट बिकॉज यू नो वी फॉरगेट ड्यूरिंग द लाइफ केस और फिर वो इंजेक्ट हो जाए, तो जस्ट मेक श्योर वो उसका.
जगदीश, बाहर फैमिली को एक मैसेज भेजो, एवरीथिंग इज फाइन एंड we have just put the lines in. The real procedure still is about to start, so not to get worried. It will take about 1 hour more from now onwards, but so far the real case is not started. The lines and preparations are taking have been completed. इतना एक मैसेज भेज दो वैभव, हाँ, not to worry, tell them.
And you've shown 3-4 TAVI in India or 2-3 TAVI?
दिखाएंगे.
ये हेमोडायनेमिक आप दिखा सकोगे ना?
हाँ दिखाना ही है तो. वो आ रहा है लाइव में आ रहा है.
हाँ, ओके.
सो अब नेक्स्ट स्टेप जो होगा, आप एपी आ जाओ, अपन लोग वाल्व चेक करेंगे सर अंडर फ्लोरो, देन विल हैंड ओवर द वाल्व बैक टू हिम, देन विल पुट द स्टिफ वायर,
हाँ,
देन विल डू प्री डायलिटेशन,
पहले वाल दिखा देंगे,
वाल्व फ्लोरो चेक,
फिर then we'll change the stiff wire. I mean, yeah.
confident. So that tells us that the message is before you put a stiff wire, you make sure your valve is properly loaded,
Yeah,
and before you do a pre dilatation, your valve is ready to go.
correct.
On the stiff wire, we take out a 9 French sheet.
Yeah, so you put the stiff wire, take out the 9 French sheet, the balloon goes,
The balloon and
pre-dilate, the balloon comes out, the sheath comes out, we go sheathless with the valve, and then we go to this angle. We go first plain LO, cross the arch, then
So
go
we'll
to
have
this
a constant harmony that the wire
Yes.
at no point of time comes
yes,
out.
Yes, yes.
So hall is full.
Valve is loaded.
Hall there.
Huh.
That's
Is
okay.
full. So
All is full. Oh, really?
simultaneous case.
France.
Bernard should be there.
France.
He's doing valve?
No, coronary.
Corner.
How is your TAVI program?
It's good.
Cross kiye the
1-8. No, Jaipur में 110 we have done 110. 110.
You had message no that Manmohan did it cross.
डाई भर के रख. कितना है आपके पास? कितना है आपके पास? 131. ठीक है, sufficient है.
Or more than enough.
More than enough, because now we'll be doing only pictures when we are positioning it. So that injection could be just 10 ml. How much is there? How much are you injecting? No. Do 10 for 10. क्योंकि हमें अब बस पिगटेल का देखना है लोअर मोस्ट पोर्शन 10 10 yeah, and then when we take a good aortogram final then probably we'll switch it to 15 for 15, so 10 10 कर दो बस अभी तो, हाँ डाई वेस्ट नहीं होगा.
Is it
5 more minutes.
proper? Watch. Okay.
Good.
Yeah.
क्या कह रहे हैं?
Sheet is just not leaking.
No, so
No,
you
it's a
put
good
the-
sheet.
you
Very
and
good
you
sheet.
put this.
Yeah.
It will not leak. Yeah, you always put that.
We put a small 9 French.
9 French 7.
That's good. So I think that's a good idea.
So no, so the valve will not leak. Otherwise, what happens is that these sheets have a valve. कुछ भी जाएगा ना उसको यूँ खींच के रखेगा नीचे. Yeah. Yeah, always put a small sheet.
दे दो ना टेबल पे तो दे दो.
Valve check, confida. Who is Dr. Mamas?
Dr. Mamas is, I have not known of him,
Okay.
but he's from Keele University, UK,
Okay.
and seems to be a nice man.
Okay.
And when I was showing an anomalous coronary arteries, cases, I was showing a trick as to how to shape the wire with the hot air by the hairbrush and all. He was taking pictures of all those things. He says, yes, you wanted to show there and there. It's true, it's teaching.
But do you have that? अब है सर आपके पास वो hot air वाला?
है ना?
है?
Hairbrush.
है?
It's ladies' hairbrush.
Yes, yes, yes.
Yeah, it's just simple.
And then you do an ETO of the catheter again, or
No,
Okay.
we reuse.
नहीं.
Don't reuse.
तो आपने नए वाले को वो किया, and then you straight go in the body, or you gonna
Straight go in the body. It's a hot air.
It's air only. Yeah, I agree.
It's a hot air.
Yeah.
So it's like this
Yeah,
air.
I agree.
Yeah.
I agree. You know.
Well, friends, 5 years of journey at Jastok Hospital with Tower has been an exciting experience, and in such period of time, we had an experience of varieties of accesses. We have had a case with a subclavian access, we had a case with carotid access, and in some cases we had to perform iliac angioplasty and then proceed, and in some cases we had to perform TAVI along with coronary intervention. I think I'm happy to know that in Maharashtra state we are the leaders in field of TAVR, and I think time has come when I can say confidently that TAVR can be offered as a primary option to all patients with aortic stenosis, degenerative variety in elderly people, and only in those cases where TAVR is not applicable that we'll have to offer surgery. Good evening. Hello, can you hear us, please? Hello. Is that Dr. Mamas? Yeah. Yeah. I need to have a little larger, little bigger volume in hearing. Your voice is faint. Okay. Now we'll show you the history, Dr. Mamas. Rahul, yeah, presentation.
So this is a 68-year-old gentleman, hypertensive for the last 10 years, underwent a bypass surgery in 2011 with a Lima-Rima Y, which was given to LED, and the Y part was given to PD and PLV as a sequential graft. He now presented with complaints of worsening dyspnea and failure, and he is in a class 3 dyspnea for the last few days, couple of weeks. Next slide, please. His ECG showed anterior wall ischemia, and he has got a narrow complex with a normal PR interval. Next slide, please. His 2D echo showed an EF of 20 to 25%, and last 2 weeks he has been on Vimada, and his EF is now 25 to 30% yesterday. He has got a severely sclerosed aortic wall with a gradient across the aortic wall of 60 by 32 millimeters of mercury, and an aortic wall area of 0.55 centimeters square. Next slide, please. A recent coronary angiography was done, which showed a patent Lima-Rima Y graft to the LAD and the PDPLV. There is a borderline lesion in the circumflex. Next slide, please. His STS score is 12, which comes to the high risk. Next slide. A CT aortogram was done for the evaluation, and the perimeter of the wall comes to around 85.4, and the derived diameter is 27. So based on this, we have selected the wall size of 34. Next slide, please. So here is the wall charting of the Medtronic Evaluate wall, self-expanding wall, which we are planning today. So based on the annular diameter, which is 26.8, and the perimeter 85.4, the wall size comes to 34. The basic requirements for a 34 wall are, the next slide, please. So the sinus diameter should be more than 31, and for our patient the diameters are more than 35, around 35 to 36. The height should be more than 16, in our patient is 25 to 28, and the coronary ostia height is also more than 10 on both the sides. Next slide, please. So we evaluated the approach point of view. This is the right femoral access approach slides.
Well, okay, fine. Can you hear us now? Did you hear, Dr. Mamas? Did you hear? Yeah. Right. So let me say what problem before we started, what we thought of this. This gentleman has a previous bypass surgery, and therefore, and that too the grafts are open. So as it is, the coronary heights are quite adequate. So that wasn't a worry. And the second thing, this patient's ejection fraction is 25 only. So we were concerned that in the past our experience is that when you are handling with this kind of heart, the wire manipulations inside the cavity of the left ventricle and the catheter manipulations and all, the heart is very irritable. And we had an occasion where we had to defibrillate the patient several times for a sustained ventricular tachycardia. So we were getting a little bit prepared about it. The third thing is about the approach, and the approach now, as you see here clearly, that there is a fair amount of calcification in the groin area and the femoral artery or common iliac artery, and there is an acute bends, almost like an omega bend. The artery goes exactly from left to right to left, and then again turns upwards. And the aorta also has, can I have the next slide, please? So the calcification, which I'm going to show you on the fluoro screen also, on top of it we find that the left has a little preferred diameters. You see here the smallest possible diameter in the left side is 5.7. For a 16 French in sheath, we need 5.2. So we are comfortable with that. But only one thing is, as you see in the uppermost panel, there's a calcification. And look at the calcification in the aorta here. And sometimes there is a bias of the instruments that we are trying to pass. And that bias can sometimes create an injury to the valve, or sometimes create a little difficulty in negotiation. And by the way, I'm very happy that in my lab today we have Dr. Ravindra Rao, and he did a fantastic case 2 days ago, and skin to skin he finished 29.5 minutes to be precise. I was measuring, and superb. We had done skin to skin, including the proglides, and he's here with us, and I think that adds to our
thank you, Dr. Mehta,
that adds
for
to
having
our
me
confidence. And next to him is Dr. Handa, and Dr. Nihar Mehta. Nihar has a great insight in the procedure, and he has shown a very, very keen interest in the structural heart disease, especially in TAVR. And I happen to be only instrumentally, I mean just by incidentally I'm here. And okay, so well, I'll tell you what all things we did so far. And so far, Dr. Mamas, any questions, any suggestions? Well, I'm honestly, I'm very comfortable with bilateral femoral, and since we are going to close this, the openings, this excess sites, we are going to close, and that will add to the comfort of the patient. Will not make very big difference.
Sizing once.
And
CT scan sizing.
And also we are been more used to the bilateral femoral approach. I know I have one case where they showed a single femoral artery placing two, but our Indian femoral arteries are not that big that you can instrument by two different sheets in the same artery. So that's a matter of preference, I believe. And the other thing is that there are
separate pacer, so you can see a pacemaker.
Yeah. I'll show you. Here it is. We have a pacemaker, and I saw Ravindra doing pacing from the left ventricle, but it's not always constant. So he also, as a safety, had kept the standby. It was not that the pacemaker was avoided, but it was there. But if we are not planning to do a pacing from these, so we have it from a jugular approach. The idea is that just in case if I have to keep this pacemaker for 24, 48 hours, the jugular is much more comfortable to the patient than the femoral. I saw a couple of cases in India Live this time, and both of them, I think it was a femoral approach, which I think is better to have a jugular approach. And this has been routinely done in our ICU, so we were quite comfortable with jugular approach.
The other important thing, if it is okay, we can discuss about the size of the valve.
Yeah. True. I think, but what do you do just in case the patient develops conduction
CHV.
disturbances? Did you hear me? Just in case if the patient develops conduction disturbances after the procedure, then you'll have to put a pacemaker because by that time the LV wire is already out. Anyway,
So
now
yeah.
so far what we did, you want to show the valve loading first here, or?
So what we
Okay.
can do?
First we did
Yeah,
this.
yeah. Let's go to the fluoro. So would you agree with the 34 millimeter size, or would anybody choose a 29 in this patient because the perimeter is around 85? Let's keep doing this.
What's the opinion? And that's the largest valve available in the market, 34. And that is one more reason that the procedural details, which I'm going to discuss in a minute, that I think is the one which I think has to be under consideration when we are using 34 mm valve. Now, question is that let me quickly show you that. Play, please. Quickly, so far whatever we did, this was the right femoral, the next one. And there is a calcium at the site of the puncture itself, so I think the ProGlide is excluded. We will not do ProGlide. And let's see if the manual compression or to put an angio-seal, we'll see about it. The next one, please. Is that the picture very clear, I hope? All right. And there is a calcium, a long
Yes.
calcium in the wall of the aorta on its medial wall. And that, I think, would have made the approach from the right very difficult, traumatic, and maybe associated with some complications. So, and the left is reasonable, like a very mild tortuosity. And at the site of puncture, that's at the femoral head, there is a fair amount of normal, or let's say there's no calcium at least there. And so we did, I saw ultrasound guided done by Dr. Ravindra Rao, very impressive, all right. But I go by still a conventional method. We did it by using the landmark of the pre-placed wire in the left femoral artery. And then puncture was very easy, no difficulty. And even the transition, or the trajectory of the wire was also reasonably straightforward. And thereafter we proceeded and see how calcified the right coronary artery and the aortic
Keep going.
leaflets are.
Keep going.
And then
We'll go to the
pigtail,
crossing. Yeah.
pigtail in the right coronary cusp,
So
coronary angio, no significant disease, and patent grafts,
okay.
pacemaker in
Next one.
place. The next one.
Next. Next. Next.
So what is your practice at your centre? If you find critical coronary disease before the TAVR, do you tend to revascularize, or do you just do the TAVR and then decide afterwards? What's your approach?
Well, if it's a insignificant coronary disease, I manage medically. But if there is a significant coronary disease, I like to address it first, followed by a TAVR at the same sitting. And there are different variations and approaches. People do it first, wait for 2-3
Yeah.
weeks, and then go ahead and do it. But I for one would believe that done in sequence at the same single sitting is comfortable to the patient, and it takes only a few cc's, unless the patient has a renal disease also. And after injecting into the artery, injecting the aorta, I found a stream of flow, and that approximately told me where the aortic opening is. And subsequently, we crossed it, and okay, so the next one, and placed the M+ catheter in, and changed over to the regular wire. Next.
Next one.
And
This is where we
then
are.
this pigtail catheter in the LV cavity. And at this point of time, now we are about to introduce the Confida wire into the cavity, into the left ventricular cavity, and
Go on.
and then thereafter, it's a
Confida.
Confida.
Would you use the same wire, or would you switch to a different wire in the floor? Okay.
Okay, and Right.
Yeah.
Now, I am, we are,
So would anybody use a Lunderquist in a
Widespread, I mean, Dr. Ankush, how widespread is TAVR in India?
say that again, sir.
Go
Can
ahead,
you-
so, yeah. You're holding the sheet? Yeah. Wire is too much in. Let's pull back the wire. The challenge in India and for the TAVR growth is out-of-pocket expense, and that is a major hindrance. So, but it is picking up. It is picking up compared to last year. Every year there's a growth of almost 100 to 150 cases. So here we have a Confida wire which is placed in the LV, and now we're going to do a pre-dilatation.
Now
Yeah.
comes the question of pre-dilatation.
Let's remove the sheet.
And this uh, no, not generally, not necessarily in every case, but here we had several points to pre-dilate. Dr. Mamas, we were using a very large valve, 34. 2, it's a very tight aortic stenosis, 0.5 centimeter is the diameter. 3, this patient has a poor left ventricle, so therefore we wanted to give some breathing space while we are manipulating and offloading the left ventricle. That may be the third appropriate reason to pre-dilate.
The other
And
thing
fourth,
is, yeah.
that we need
Yes.
not do a post-dilatation once we have done a pre-dilatation.
Yes.
What do you say, Ravindra?
I agree, and it allows us to place the valve a little higher, especially a 34 millimeter valve. It tends to dive in. Now, if you want to do a shallow implant, we always want to avoid a post-dilatation. But what is the comments from the experts? Would you pre-dilate this patient in your practice or no? Okay, go ahead. Pace at 180.
Pace at 180. Yeah.
How confident you are you can deliver the valve. I generally don't
Negative.
in the majority of my cases. I probably would,
Yeah.
Okay,
Stop
stop pacing.
but I don't think it's wrong either way. I think it's dilate, I probably would.
Okay, off fluoro.
A lot of it comes from experience, don't you know, yours is an experienced centre.
Any tips and tricks you want to share with us implanting a 34 millimeter valve? Fluoro.
Essentially, we do around 300 TAVRs
Mhm.
a year, and we've done that for many years. I think the important thing is information and planning up front. So, as you very well showed,
Mhm.
doing CT, showing, looking carefully at calcification before you want
Okay, so sheet will come out now.
sizing, having, a second operator check the sizing on the CT. I generally don't use external temporal wires. I pace over the wire.
So here you see the 16. Yeah. So you see here the 16 French sheath is out, and we'll be using an inline sheath to deploy this valve. Okay. So come to AP view, please, and show us the wire first in the LV. Show the wire first in the LV.
Down,
Yeah,
please.
Leave the
Down,
wire.
down, down. The
Okay. Push the wire.
Okay,
Push the
push.
wire. Show the wire in the LV. Yeah. Leave the wire. With me. Yeah. I'm holding the wire.
Right,
Go ahead.
right. So, so go to the groin, please.
Go to the groin.
Groin, please.
So we removed the 16 French sheath, and now this
Okay.
is a sheathless inline sheath which comes with the 34 millimeter valve. So if you have to do the 34 millimeter valve, show the wire in the LV also, please. Okay.
Yeah,
Now
it's okay.
suppose if you have
We'll
to
keep it the wire level only.
If you have to use a sheath, you need to use the 20 French sheath to deliver a 34 millimeter valve. But looking at that calcification, we should take the advantage of an inline sheath. So this
Okay.
is where we are now.
So now we'll advance the valve now.
Leave the wire. Yeah. Go LAO, show the arch.
Hello, please.
Okay, go ahead.
And fortunately, it's a
Leave the
smooth
wire, leave the wire.
entry.
Okay.
And
go
go
ahead.
to the implantation view, please.
Yes.
We will see now.
Okay. Center.
Just
Center.
center, please. Center.
Zoom.
Zoom it, please. Big Mac. Okay.
good, go ahead, let's go
And
ahead.
then I just enter into the.
Okay.
It's entered.
Yeah.
So now we'll
L-
make a small injection, please.
Yeah, so let's take a small injection to identify the position of the pigtail. Yeah, inject,
Inject.
enamel. So you see our pigtail is not at the bottommost portion of the non-coronary cusp, so we can push it down. Good. And next we go
Inject again.
Yeah.
Inject again.
Good. And then we can
Okay.
go caudal, remove the parallax. Caudal, please.
Little more caudal. You see the circle that we see for the
Go
people
cranial,
in the
go
audience.
cranial.
that
Go cranial.
this.
Slow, slow, slow.
Yeah,
Stop.
but I think that's
Good.
fine.
Yeah.
That's fine. Come back a little bit. Come back a little bit.
Yeah. Okay. That's good.
Okay. This should be okay,
Yes.
Ravindra.
Yes. Yes.
This should be okay. All right.
So-
So I think we should start deploying here. and
Yes. Yeah.
at
So
this
we what?
point, I
So
think
exactly. So
it's
this
okay.
is
His position, Dr. Mamas. What do you think of positioning?
Yeah, I think it's probably okay. Slightly lower down, I would say, but
yeah.
Okay.
So it just come back a little more because this, as I said, no, this valve tends to dive in a little. Let's have the hemodynamics on screen. Let's have the pressure, please. Okay. Okay. So what we'll do is we'll try to open it here slowly. And the other important thing is you see the catheter has to be on the outer curve of the ascending aorta, so you are perpendicular to the annular plane,
Which we are.
which we are actually. So we're going to go very slow.
I think it
Yeah.
is.
Yeah, push it in a little.
Need to be a
push.
little bit.
Yeah, push in. Okay,
Is that?
A little in forward.
good. Let's go ahead and capture this one. So yeah, just go a little bit deep in. Okay, let's take a picture here once.
Inject.
Okay, inject. Okay.
We're a little bit more deep, no,
Yeah,
Ravindra?
so we'll just fluoro.
Yeah, floor is on.
Okay, that's good. So we're going to start here.
Yeah.
So maintain a forward pressure on the wire. So you see a lot of ectopics here. Sometimes we would like to pace. So pace at 140 here, please. Just go a little deeper. It tends to come out. Yeah, just pace at 140. Just go a little deep, sir. Just a little deep. Yeah, it tends to come out. Yeah, yeah, yeah. This is good. So we're gonna pace here at 140, and we see that because there were so many ectopics with every heartbeat.
And not only that, at this pacing, the pressure is very good, maintained.
Yeah.
There is no difficulty.
Yeah, good. So we're gonna go a very slow opening here. Yeah, good. Yeah, let it open up. Okay, let's take a picture here. One injection.
Inject.
Good.
I think
So
it's
then
good.
this looks good.
It's very good position.
Okay. Continue pacing. Yeah, continue pacing. So it makes annular contact, and that's where the pressure goes down. So you keep going slowly until you hear the click and the pressure comes back. So stop pacing here. Fluoro save. Yeah. Yeah, completely stop. So can you see the hemodynamic screen?
Just show the pressures, please.
So you see the pressure has come back, and there is good diastolic pressure,
Except one thing that Ravindra has.
LBB?
LBBB, yeah.
but
Little-
still in
little-
sinus rhythm.
Still in sinus with normal PR.
Yes. So let's take a picture. Let's remove the parallax from the valve. Come a little caudal, please. Good, good, good. That's good. So let's take a
Okay.
picture.
so are there any tips and tricks for the
Okay.
Yeah. So what do you think about the depth? Play that picture again.
a bit borderline,
You mean to say?
about okay.
Yeah. Play that picture. Play the cine which we just took. So you see on the non-coronary cusp.
No,
No.
no, no, no.
So we are
Yeah.
right there at 3 millimeter. On the other side, we are almost touching. It's also 3 millimeter. And
Yeah.
what do you think, Dr. Mehta?
I am comfortable.
Yeah,
with
I'm
this.
also comfortable with this position. So I think we'll go ahead and release. But the important thing is, see, this valve will tend to pop out. This valve has a tendency to pop out if we are not maintaining a forward pressure. So how much forward pressure to apply, that you can judge by the position of the catheter in the ascending aorta. So now if you push this catheter too much, it can come out from the other side. You see, you're already there on the outer curve. So
Yeah.
just a gentle forward pressure, you know, just allowing
Yeah,
the
yeah,
uh,
precisely.
yeah. So we're gonna go ahead and release, but we'll jail our pigtail. So very slow, just maintain a forward pressure. Very slow opening. Maintain a forward pressure. Yeah. Slower. Okay, just maintain a forward pressure. Good. So we're gonna allow one side to come here. Okay, good. So you see how you're releasing a spring, forward pressure? That's very important. Okay, so that's full release. Okay. Fluoro, save that, please. Yeah. Okay, and before you pull out the catheter, you make sure both the tabs are released. So I think both the tabs are released. Now we're going to pull back the wire, centralize the nose cone, pull it out here, and then you push your wire again. Okay.
Okay, I think
so
that was very important
yeah.
because in the last case in Reliance Hospital, we made a mistake and the nose cone which was stuck, no,
Mhm.
it pulled the valve, the
Valve,
valve
that can
back, and then
happen.
I had to put
Yeah.
another valve.
Oh, but that's
Yeah.
very important. You need to centralize the nose cone. So now what we do is we retrieve the nose cone. Come to AP view. Okay, go ahead. Okay, make sure the wire
Wire, please,
stays in
wire
place. Okay. Prepare. Push the wire, please. Push the wire. Prepare the sheath again. Okay, so let's walk it out. Walk out everything. Yeah. Make sure wire stays in place.
Wire stays in, please. Just show me a lower down, please.
Yes, this will
We
come
are
out.
in. That's
this
all.
will also come out.
That's all.
Yeah, okay. So you see the inline sheath comes out now, and we'll put a 16 French sheath back in,
It's on table, sir.
and then give us a pigtail. Pressure, please. So what is actually happening at this point of time? You are
Sheath,
also
please.
allowing the valve to fully expand, and so we would not like to take an aortogram at this point of time. So we'll allow full 10 minutes for.
Decide whether you do dilation or whether you're happy. What factors?
So three.
I bet
Yeah.
that
Yeah,
would
hold it.
depend upon what the aortogram
So
shows.
three things. We're going to do a hemodynamic assessment. We'll show you right now. Push it in. Yeah. Fluoro. Hold the sheath. Hold the sheath. I'll remove. You're holding the sheath?
Yeah.
Okay.
I'll remove it.
No, you'll have to hold the sheath. It will tend to come out. This is very hydrophilic. Yeah. So three things. You look at the aortogram. You look at the hemodynamics. Let's put the pigtail. And you also look at the echo.
So,
yeah, go ahead, sir.
well, I think we'll advance the pigtail and
Yeah. So in hemodynamics, you look at the AR index, which is the difference between the LV EDP aortic diastolic divided by the
but
systolic.
as it is,
yes,
Ravindra,
Yeah, I
aortic
agree.
pressure is 70 diastolic,
yes,
and which was the same as to start with.
agreed.
So now here,
So we're gonna go into the LV, and we'll
Yeah.
show you hemodynamics. Okay. Can we have the pressure tracing? Pressure, one more pressure here. Okay. Flush, please. So yeah, right there. Can you see the can you see the hemodynamics on screen?
Dr. Mamas,
So
do you see the hemodynamics on the screen, please?
so no gradient and no AR as per the
And,
hemodynamics.
LVADP also is normal, and the diastolic pressure is about 70. That is what we had started with.
Yes.
The
And-
only thing is that about the left bundle branch block is also now is minor as compared to what it was, and we would be observing him in the ICU,
Fluoro.
and I'm not,
Let's do a fluoro. We'll
it's
show
quite
them the here.
possible that there may not be any need, and this bundle branch block may be transient only.
So we'll do an aortogram. Let's remove the parallax of the valve.
Can you come green?
Caudal. Caudal. Just AP. Caudal.
But I'll remove the LV
Yeah,
cavity
yeah.
pressure. Yeah.
We'll just show you a final aortogram and
I'll place it here.
yeah. So you heard that the AR
Our
index is 40.
AR index is 40.
Okay. Yeah.
And
Okay. So pigtails have married each other. Okay. Let's give us a wire, please. Wire. Just a wire.
No,
So you-
I'll tell you
Yeah.
what, Ravindra.
Yeah.
Just simply pull one pigtail out. That's
Becau-
all. I'm holding the other one.
Okay.
No need to wire it even. Just simply pull the other
They
one.
don't want to separate. See? It's like eternal bond for 7 years, you know,
Right.
Indian marriage.
Yes.
So we'll take an autogram here.
Talak, talak, talak.
Okay, ready for picture?
Sir, you have to connect it there, no? Yeah.
It's connected.
I'm ready.
Yeah.
Ready?
Yes, sir.
Okay. There is AR.
So what we do is, by the
There is
time you
AR.
go there,
The wire is migrated down a little.
no, that's okay. So what we do,
There is chest of AR there, you can see.
yes. What would you do here? Would you do a post annotation?
I would
We
say.
can do a post annotation because our depth is good. What we'll do?
no,
right-
I think that thing is that we have seen sometimes that what looks here today,
Yeah.
2 days later, because it's a nitidol,
Yes.
so expands and reduces, and the diastolic index is 40, 40, which I think there is at least no acute AR, right?
Yes.
That's, look at
Yeah,
the pressure
yeah,
tracings. Dr.
But-
Mamas, what is your suggestion?
I mean, I guess it depends on how severe it is on echo. I would probably post dilation.
Yeah, we will do a post annotation here, and what we'll do is by the time you come back from France, we'll show you a picture after post annotation. Is that
Right,
okay?
right, I think so. All right. So,
So
get
we'll
us the
do
wire,
this.
please, again.
Yeah. Okay.
Thank
Go ahead
you,
advance
and
the picture.
Get that 26 balloon.
Let's go ahead and push the pigtails here. Let's just cross.
Just check there.
Yeah, this one. This is the pigtail, sir.
So this one.
Yeah, just push it into the LV. Just push it in. That's it. Confident.
So you want 26?
26. That's okay. Because now pacing will be very important. So Nihar, which you were saying the depth, no. Actually, we have changed the angles now.
Yeah, but still, it's looking a bit deeper.
It's
than-
little deeper.
Then we
That should
started.
be-
That time it was 0. But that's
Yeah.
okay, sir.
It's not bad actually.
It's not,
the
it's not.
result is also not this acceptable.
Okay.
Which balloon you are taking?
26, sir.
Okay.
We're good. See, diastolic is around 67, sinus rhythm.
No, but I tell you, Ravindra, it will be much less.
Yeah, I
2
agree,
days
sir.
later
It will not be there. But just for the autogram, just for
Mm.
the audience.
after
Yeah,
dilatation.
yeah. Just put the balloon. Give me a 10 cc
Nihar?
syringe also.
Nihar, we are off the screen. We are off the screen.
They'll come back to us. एक काम करते हैं, hold on. Okay, let's go.
It's on fluoro, sir. We are on.
Fluoro?
Fluoro is on. Huh?
We are on 2 minutes more, sir.
Yeah, yeah. So
Okay.
we'll just, yeah,
So
we're
we'll
gonna
show the
post dilatation. Let's
post
go ahead.
dilatation, and
So we've selected a 26 millimeter balloon. Let's go ahead and push it in.
it's little hard to push.
Show us above what is happening.
No, it's sticky.
No, above. Okay,
Yeah,
let's go in.
we
more.
should be a
Little
little
bit
bit
in.
more in.
Little bit more. Little
Yeah.
bit more. Little bit more. Okay, that's good.
Okay,
We are pacing.
shall we pace, please?
Pace, sir, what?
180.
180.
Yes, sir. Started already.
Are we on floor, sir?
180.
180, yeah.
Okay.
Pressure goes down.
Yeah, go ahead.
Okay, we'll have to do it again. So stop
Do it
pacing.
again.
Stop pacing.
Yes, sir.
Let's go in. Let's go in. You pace at 200. We'll ask you to pace at 200. Go in a little. Go a little. Sir. Okay, pace at 160.
Yes, sir. 160.
Okay, go up on 180 now.
Yes, sir. 180.
Okay, so stop pacing. We'll go a little bit deeper in. Just go deep, sir. Go deep. Little deeper. Little deeper. Little deeper. Little more. Little more. Good. Okay. Pace at 180 now.
Yes, sir.
Thank you everyone for joining us. The session has finished.
Okay.
Yes, not good.
Good noon, Doctor.
Stop, sir.
No. Stop pacing now.
With extra CC is helped.
Wiring.
Moving on to the section on complex coronaries, I would request our next chairpersons and moderators to be on dial
Remove
for
this.
next session.
Just do a negative. Do we have time to show the final aortogram? You can, no, ask them to. We want to show the aortogram. निकाल दो, कोई बात नहीं, निकाल दो सारा बस. Yeah. So can we show an aortogram?
Ready.
So the reason why we are not deep, we are still in sinus rhythm. See,
Would you like to see our final record, Dr. Mamas?
are we on?
Yeah, we are on, but I think we are changing the chairperson.
So let's take an aortogram.
Shoot. Oh yeah,
It
much
has
better.
gone down.
Much better.
1
Much
plus
better.
AR.